Hi, and welcome to Faculty Focus, a podcast supporting the clinical education community in Leicester. We bring you Educator CPD, showcase new initiatives, and shine a light on some of the faculty behind it all.
Right, well, hello and welcome everyone to this episode of the Faculty Focus podcast. I'm joined today by one of our occupational health consultants, Dr Harj Kaul. He has a specialist interest in neurodiversity. Now, why have we chosen neurodiversity? Well, it's something that probably a lot of us have heard about, and it actually came in from one of our listeners as a request that actually could we have a look at neurodiversity as a topic within education, because it's obviously of interest to a number of our listeners. And it's probably something that we don't really talk that much about. We sort of have a rough idea of what it might involve, but there's a lot more to it. So as it happens, we've got someone with a very keen interest within the Trust, and we're joined by him right now. So Harj, would you like to sort of introduce yourself, give us a little bit about where your interest is in this area and how involved you are, and how you got into it, I guess.
Okay, thanks for the invitation, Andrew, as well. I know we've been trying to organise this for some time. So eventually you and I managed to find us a sweet spot, both of our windows, for us to have a chat. And so if I give you my background, this is just for the audience, I'm an occupational health physician. By that I mean what my interests or specialities as a doctor, yes, I am a doctor, okay, is to do with the impact of work on health and the impact of health on your ability to do your work, right? And so my original interest in all this started more than 25 years ago, because as a trainee, when I was in Nottingham, increasingly I was involved with undergraduate nurses. And it was all to do with screening and support in order for them to get through their 3-year training program. And I started to see dyslexia being presented, okay, at that point. And I thought that was quite interesting from my perspective, because it kind of hit on where my personal interest was teaching education, and obviously my specialty, occupational health. And so when I became a consultant in 2000 here in Leicester, again, we still continue to provide the contract for the De Montfort University, where I became the lead for DMU. So DMU at that stage had just nurses, and then I did a bit of ODP, practitioners. It's all to do with screening, supporting them from a undergraduate perspective, and then them becoming employed. And there was a bit of a concern at that time that student nurses with dyslexia and nurses who are newly trained with dyslexia were at risk of making mistakes when it came to medication and things like that. And so there's a lot of kind of stuff going on between the RCN and as well. And then the research was done, and he actually found that individuals or nurses with dyslexia were actually better and less likely to make mistakes. And the reason was that because they knew they had dyslexia, they actually put more effort in learning the names of the drugs. If you remember, you being an anaesthetist, sometimes, names of drugs can be slightly confusing, okay? And sometimes names of drugs get changed over time. And so that's what I found quite interesting, is that the perception was that things would be difficult, the natural perception, but the reality was, when you looked at the evidence base, that it wasn't. Now, so that's going back to 25 years, so I've always been interested. And what have always fascinated me was looking at the educational psychology reports, which probably makes me really odd, okay? Because a lot of my peers at that time would say, oh, dyslexia, that's an educational issue. What are you getting involved in that for? And I always thought, well, it's never as simple as that, because each time I spoke to some of these individuals, there was so much anxiety, so much emotional issues or low confidence that they had coming to a work environment, not just nurses, but lots of individuals. To me, it was way more than just a learning problem. Okay, so I continued with that interest for many years. And then I remember maybe going back 10 years, there was a medical student with ADHD, because by that time I was also the lead for the Leicester Medical School with all their intakes and supporting trainees and undergraduates going through that. And she was an interesting character in that she got a master's at some London university, coming to do medicine. And she was struggling to the point where the head of school came to me and said, she's had the worst score in her first year with MCQs that we've ever seen. Okay. And the general kind of feeling I was getting is she would not be good enough to get through the training program. Okay. And I thought, okay, well, I don't know. I'm not going to make an assumption here. Let's just see what happens. And basically, I used to see her regularly every 6 months or whatever. And they're to individuals with, not all individuals, but some individuals with ADHD can be quite impulsive. And this individual had found herself, shall we say, using those special herbs and tablets at one point during her career. Okay, so I was involved with that. Some of her behaviors were somewhat impulsive. Okay, but, you know, we talked through that, and my approach to occupational health has always been bespoke. Okay, and, you know, every individual presents a different situation. There's a well-known phrase in for example, in autism. Okay, which is just because you've seen one person with autism, guess what? You've only seen one person with autism. You haven't seen the whole community with autism. So this is what I've discovered, is that over the years, is that just because somebody's got a particular label, or not a label, of autism, ADHD, dyslexia, dyspraxia, whatever, okay, is their presentation or their function is a very individual and unique to them at the end of the day. And so I've always kind of been interested in individuals with those kind of combination of presentations as well.
Yeah.
Okay.
You've mentioned quite a few diagnoses there, or conditions. Is there an overall sort of definition for neurodiversity, or is it really just a case of each one is very much a different thing?
It's an interesting story there, Andy. Okay, right. Well, this all go back to 1997. Okay, and there's a Australian sociologist in her 40s who kind of coined the phrase neurodiversity. Okay, and the definition of neurodiversity, as she mostly has evolved, is it refers to kind of a infinite neurocognitive variability within human beings. Okay, so basically we're all different. Okay, and that the fact is that every human being has a unique nervous system with a unique combination of abilities and needs. I think that's a reasonable definition to play with, that we're all different. In the same way, so that's really what neurodiversity is about. But I always think of it a bit wider than that, because if you think about it, some of us can run fast, some of us can sing. Okay, some of us can bake, some of us can cook, some of us got good hand-eye coordination, some of us can draw, some of us can't. Okay, so I always try to look at it much, much broader than that. Okay, but there also happens to be a neurodiversity movement out there. Okay, which I find quite fascinating, and how more and more doctors are kind of owning up to having some form of neurodiversity. Okay, and kind of a broadest definition of neurodiversity, I would say, is that there's been a kind of a shift in the mainstream, that those of us who are slightly different, we shouldn't be marginalized. We shouldn't look at our abilities, okay, as being negative deficits, but there may be some gifts and needs for that. And also society may benefit from those of us who are slightly different. Okay, so I have noticed that within the medical profession. I'm not going to spend time talking to you about what I think beyond medicine, okay, but this is what I've noticed at the end of the day. Yeah, if I go back to sorry. Yeah.
Oh no, I was just going to say it does sound like we I guess in medicine we're always trying to we have to draw lines, if you like, in a spectrum of results or things that you see. And if you think about blood tests, for example, there's a whole range of normality, and then we have to draw a line somewhere and go, well, this is now abnormal. And actually, it's from what you're describing, it's like you say, there's a whole range of abilities out there, and at some point, I guess when things fall out of what is considered normal, then you would attach a label to it and say this is a condition you have. Is that a sort of fair assumption of?
Yeah. I mean, you've probably heard the term spectrum.
Yeah.
Okay.
Yes.
Kind of mentioned within the neurodiverse world. Okay. And for example, the common one is autistic spectrum disorder. But even language is important. ASD, autistic spectrum disorder, a lot of kind of people who write about it or talk about it would say, well, actually, it's ASC, it's a condition. The disorder kind of indicates dysfunction, a problem. Okay, so again, you'll notice if you get involved in this situation, like I do a lot, is you have to be careful with wording. At the end of the day, as well, we have to. It's a society we're in. Let's not go down the gender, chat. Okay, but you know what I mean. Okay, we just have to. All of us have to be careful. And I've always found it much easier to say to an individual, "How would you like me to describe the set of functions that you have, or what do you feel comfortable with?" And that brings us on to, if you're going to carry on chatting, Asperger's. Some of us may have heard of Asperger's, which is said to be, was defined and still is in some circles as a high functioning, high IQ, but a particular set of functions. Okay. About a year ago, one of my colleagues said to me, that we shouldn't be using that term. I says, how come? Well, she says, well, basically because Asperger's was a German clinician, and part of what he did during the Second World War with the Nazis' time was to identify people who are not, should we say, normal, whatever normal is. And some of the children he identified as not being normal or having functional deficits, he sadly kind of assisted in sending off to camps, shall we say. Okay. Yeah. So within the world of autism, some people still want to be called, I've got Asperger's. Some people say, no, I'm not going to be associated with that term anymore. Okay. Right. So again, it's like I said, it's an interesting world. I find myself in trying to navigate through language at the end of the day. But Andy, you come up with a really interesting point about kind of negative part of what medicine, I think, one of the things we do in medicine, we look for abnormality. Otherwise, how do we start treatment or not treatment, operate or not operate, because we're looking for something abnormal at the end of the day. And in a way, going back, because I think I'm a bit older than you, Andy, okay? So, in the old days, there were people who were, shall we say, would be in the thick class or the dunce class, okay? And I'm going back to the 60s and 70s now, Andy, okay? And so I remember meeting a few patients and nurses with dyslexia, and again, one of the issues was, I found, and still is a problem, a challenge, is that the perception they have is that they've struggled throughout their life with challenges, and therefore they've struggled throughout their educational journey, undergraduate, primary school, whatever. They knew they were slightly different, but couldn't put their finger on it. The family knew they were slightly different. The family couldn't put their finger on it. Okay. And then they're trying to fit into society. And as an occupational physician, for me, that's to do with a job, trying to fit into a job environment at the end of the day. And I would say in the last 3 to 5 years, what I've noticed is that the kind of recruitment practices, okay, because of the Equality Act 2010, which is kind of this legislation, okay, that individuals who are disabled have protective characteristics, and there's nothing wrong with some kind of positive attempts, okay, to get them into work. But in order to do that, you have to kind of have the recruitment processes which meet their criteria to assist them to be able to be recruited effectively at the end of the day. And some firms, I'm talking about outside of medicine now, have proactively engaged in employing people, say, with certain neurodivergent traits. For example, in the technology sector or the IT sector, or say, I'm aware in the banking sector, because individuals looking at their strengths have got positive abilities to concentrate, focus for long periods of time. If they have a special interest in mathematics or whatever as well, is they can come up with stuff.
Yeah.
Okay. Yeah. And I think before we had a chat, I shared with you, my particular thoughts about what I call the STEAM professions. Okay, or the STEAM occupations. This is when I think STEAM being the acronym for science, technology, engineering, arts in the broader sense. Music, creativity, acting, and mathematics. And I think that individuals who have neurodivergent traits probably do better, and increasingly you would have noticed is many individuals who are quite creative in innovation in business even, or in the arts, are openly owning up and saying, I've got ADHD, I've got this condition. Where there was a time nobody wanted to own up to anything because nobody wanted to be different in case it was a negative thing.
Do you think in medicine that there are specialties within medicine that you could say seem to sort of attract certain personality types? I mean, I guess there's always the kind of stereotypes of various things, but maybe I don't want to answer.
I'm going to be careful here. Let's not talk, Andy. Let's not talk about surgeons, okay? Especially orthopods.
Yeah, anaesthetists have a bit of a reputation for being a bit OCD. I think that's fair to say. Most people would have heard that comparison, but I mean, I suppose that's one of the great things of medicine is that you can find a place which sort of suits your skills and abilities. I think that's always been my impression. But
I agree with you. I think that the thing to remember is I was at a talk recently. I was trying to explain to somebody that there are 66 different professions after hopefully successfully completing your foundation training program is one can launch into. There's always a niche. Hopefully, even if you take the portfolio route, that's probably one of the things I do when I have undertaken occupational health assessment. And luckily for me, I guess one of the experiences I bring to the table is that I'm involved in education, in that I'm an educational supervisor. I've been an examiner at an undergraduate and postgraduate basis for a number of years in the past. I'm a TPD. I'm a national TPD for the National School of Occupational Health. So I've got. But also at the same time, I'm also a clinician who face-to-face, sees patients, which for me increasingly are doctors, okay, rather than the broader patients, okay. And so I've kind of straddled between understanding the educational journey world, the concept of what an e-portfolio should look like and ARC panels should be doing, okay, because I chair many of them, to on the other side, looking at it from a work perspective, as in you still need to have enough skills and safety to do your job and also to engage with your learning processes at the same time. Okay, so this is where I'm involved with a lot more now.
Yeah. So what sort of, we've talked about some of the condition. I mean, I just had to sort of Google and find out what sort of things we're talking. You mentioned some of them, the ADHD, the attention deficit, and autistic spectrum. And then there's the things like dyslexia, dyscalculia, dyspraxia. What sort of things, I guess you've seen this at ARCP panels and been involved in the training side. What sort of things tend to be, how do they manifest these things? What often is the thing that gets written up in end-of-year reports or things sort of like that?
Let me take you back slightly before then, Andy, I think, because I work at the undergraduate and postgraduate interface, okay, if you could perhaps go back to the undergraduate interface, what I'm noticing is that there's a lot more individuals identifying with neurodiversity or entering medicine. Okay, because I see those cases on entry. Okay, and in very, very broad terms, what I notice is that generally for the first 2 years, because it's roughly academic based rather than experiential apprenticeship model training, depending on if I use the expression penetration or of the challenging behaviors, okay, generally most people do fine first couple of years, okay. Where I notice more struggles is years 3, 4, and 5, purely because there's much more clinical learning expected.
Yeah.
So if I give you a broad typical case, if an individual has a combination of dyslexia, which is really, in simple terms, kind of a learning, small-term memory kind of process, in very broad terms. If they've got ADHD, okay, so it's more to do with organization, time management. And if you've got autism, and then it's more to do with kind of social interaction and the ability to have effective communication with individuals, okay? Great empathy, people with autism have. But, so you find if you have those challenges in your function, as you try to progress through your 6 weeks placements, moving, same time trying to move between different hospitals, same time trying to do your increasingly more difficult exams, things start to come slightly unstuck in years 3, 4, and 5, okay? Having said that, I would say the majority, and I do mean the majority of undergraduates I've seen with that combination of functional challenges, okay, have done really well. Okay, but you do occasionally come across an unfortunate, difficult or so-called sad case, I see, where the conversation or becomes a bit more difficult between me and them, because I have to try to remind them that the undergraduate training program is really about being a qualified F1 doctor, having the ability to actually work within teams, with people, different environments, different hospitals, multidisciplinary teams, blah, 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 blah. Okay. It's not about just passing the exams. Okay. And again, you may or may not, an audience may know that, 25% extra time for the written exams, but, it's generally accepted that should you be given 25% extra exam for the clinical component? Because to me, the clinical component is the core of the job. If you struggle to process a history, examination, the concept of a diagnosis within a reasonable period of time as an undergraduate, then the chances are, as a postgraduate, you are going to struggle.
Yeah.
And so it's a challenge, and I think it's sad, okay? But sometimes they are the rare individuals where the career is not going to go in the direction they've set their passion on, and the family have set the passion on, okay? And these can be tricky conversations, things to deal with throughout the different medical schools across the UK. And if you're going to go into the apprenticeship model, let's not even go into the new models and the new medical schools and, all the other things that I know happen. There's certainly, I would say to you, there's a postcode lottery of guidance on decisions being made, I suspect, across the undergraduate and the postgraduate situation when it comes to supporting doctors with neurodiversity. Okay, and I think that's something that bothers me.
Yeah. So
and part of what I've done, Andy, is I'm also an advisor to COPMed. COPMed is the combined group of postgraduate medical deans across the 4 devolved countries. So I'm the occupational health advisor to COPMed and neurodiversity as well. So you can see I am genuinely interested in this, and I genuinely think that the majority of doctors with neurodiversity, as long as they're working with the right people, okay, in the right jobs, okay, in the right environments, will do exceptionally well in their lives and in their careers, because they're talented. And let's not forget, doctors with neurodiversity are not the same as the general public with neurodiversity, because doctors with neurodiversity have already shown a significant level of intellectual capabilities, emotional strength, drive, passion, interests, okay, to get into medicine. Okay, because the ratio, I think, is something like 1 in 4, 1 in 5, even now, to get into medicine. Okay, but even those, great, good individuals, with neurodiverse doctors sometimes need to take a sidestep and a reflection on their career, that the skill set that they think they need, they may not fully possess to get an outcome 6. okay, to become a specialist in their chosen field. And this is when, ARCPs and the postgraduate deans and the pastoral support wellbeing units have challenges. Trying to find a sensible, balanced way forward.
Yeah. So, as you're speaking, I'm sort of thinking back to sort of scenarios and situations I found myself in or observed. And, certainly the rotations through all the different hospitals on a regular basis with different teams and the pressures of postgraduate exams on top of that and the sort of on-the-job assessment. I mean, it's stressful for anyone without any, sitting on this on the end of the spectrum and having those difficulties. So one can only imagine, if you've got if you struggle in those areas like the social side of things, or not being able to find the right words, or not being able to think in an abstract sort of way, perhaps
abstract
easy.
Or a timely fashion. Okay, it's a challenge.
You can see how it's going to build up. So I guess people often see, if you come across an individual who maybe doesn't realise they're at the end of the spectrum in terms of what's considered normal, they come across, I guess, as being like difficult, rude, awkward, I suppose maybe slow on the uptake, some people might say, depending on what it is that they're hoping to learn, I suppose. Are there any other sorts of things that people might notice and think maybe we should think about putting in some support or letting them have a conversation with?
I think I guess I'm putting on my educational hat on now as ES. I think it's important, and more so these days, is for any trainer to have a psychological safe space, as in be able to create an environment where you are able to get to know your trainees. Okay, and that is one. It's a skill, I think, to be able to make your trainee relaxed enough to trust you to talk to you. Okay, at the end of the day, it's time. Okay, and sadly, I'm not sure the time is there or should be there, because there's staffing issues and there's post-pandemic pressures and blah blah blah. There's a lot of other issues there. But if there is the East Midlands approach, I would suggest is slightly different in that we do have a good functioning pastoral support and wellbeing unit, the old deanery. Okay. And they uniquely across, the other deaneries in England definitely have commissioned experienced occupational health physicians like myself and a couple of my colleagues. And we provide kind of a regional, East Midlands regional kind of specialist occupational health service. And we're the characters who've got a genuine interest in what's known as practitioner health, as in you are a healthcare practitioner. And we're not broadly trained. We're very specifically trained to look at the challenges of being a doctor working in the current climates, because we understand what the pressures of the current climates are. So we're beyond just the local service. We're the kind of regional service commissioned by the HEE. So between three of us, we've got lots and lots of experience of supporting them. And I like, for example, was it last week I saw an SD1 with dyslexia. I think this week I saw an F2 with dyspraxia and ADHD. A couple of weeks ago, I saw a medical student with dyspraxia and ADHD. I remember seeing a ST3. I'm not going to name the specialty, with autism. And so again, I've got lots of experience.
Yeah. If the, in the long term, if individuals haven't been identified or maybe they haven't come into contact with any sort of support service, are there long-term consequences for these individuals? Do they, mental health problems? Is that high risk?
Sadly, it's a good point, Andy, you make. Sadly, it's well recognised that anxiety is associated with neurodivergent individuals. To me, I think there's a double whammy here, in that I think medicine attracts individuals with OCD and perfectionism anyway. Okay, because we check, double check, triple check, we're not going to make a mistake. So, for example, having that particular talent and skill set in an anaesthetist would be useful. because you're not going to give them the wrong medication or whatever. You're going to double check the OTs and everything's on at the same time. Keep an eye on everything because you don't want things to go wrong, okay, let alone the wrath of the surgeon, okay, when it's their fault, not yours, Andy, okay? But, okay, so what I'm trying to say is medicine attracts people anyway with perfectionism and OCD anyway. Throw into the mix, okay, some form of neurodivergency, okay, it makes them complicated for them. If somebody with neurodivergent has a degree of autism traits, already they're struggling naturally to make friends or comfortable. I mean, there was a term used with me this week by one of my doctor patients was, I'm very good at making skin deep, relationships, but that's it. And I think what I've learned over the years is that, especially because we have very bright doctors, okay, they've learned to mask, okay, they've learned to kind of play, if you use that expression. One of the things I sometimes say to doctors, and this is not all doctors, not just neurodivergent ones, is as a doctor, we're like actors. When we come to do the job, we're performing. Let's be honest, okay? But we sometimes forget to stop performing. We need to switch off. Like last week, I was asked to do a talk to burnout, to LPT, locally employed doctors. And I was just trying to explain to them. Strange thing, I says, the secret to surviving burnout, I said, is stop being a doctor. When you're a doctor, and when you're not a doctor, stop being a doctor, okay? And try to be normal, okay? And try to do the things you enjoy doing, not doctoring, okay? But, things like running, creativity, singing, baking, gaming, running marathons, playing in a jazz band, whatever you want to do, just do it. Write poetry. Stop being a doctor if you want us not to have burnout. Yeah,
I mean, one of the things I do, I often sort of make it explicit when I'm with trainees in the theatre environment is that, I guess it's that, like you say, that play, that impression you want to give to those around you. And often that can come at a cost of performance and abilities because there's so much cognitive capacity spent on how does this look? How did I come across? Have I not offended? Like you say, playing that game, that less attention is spent on the doing the job. And I'm always aware of the impact that observation can have on individuals because it is a performance, isn't it? The way you act in front of a patient is different to the way you act at home, and we all put on these different sort of facades, don't we? So masking, I can see that being a coping mechanism.
Yeah, he does come in, and I think in some of the sad stories I've heard, I remember seeing a doctor who is autistic, and he's quite open with me about it, and he used to be in a training program. Okay, and he stopped being in a training program, spend more time doing bank work, locum work. Okay, and the reason he changed, he says, because you remember when he was a trainee, he was struggling with the exams and everything else. Okay, and with the shift work, because one of the core issues I recognise with doctors with neurodiversity or anybody with neurodiversity is change. You like what you like. You get used to working in a certain way, working with certain people in a certain ward, certain environment, and then your training program says, oops, thank you very much. After 6 months, a year, whatever it is, off to wherever else, somewhere else. And you think, hold on, I have to change my whole routines when I've just settled into being comfortable where I am. And individuals with neurodiversity, I think it's a greater challenge for them, okay, than it is for what is termed neurotypical people. Against neurodivergent human beings, okay? I think I recognise that. I've seen that quite a few times, okay? And what he said to me was he did actually open up one day to his trainer and said, look, I've got autism, okay? And the doctor turned around to me and said to him, well, you don't look odd, okay? And he said to me, well, I didn't understand what that meant, okay? And I said, clearly what he means is you don't look like you've got Down syndrome, learning difficulty. Can you see the confusion that can happen? Therefore, how can you blame somebody for neurodiversity wanting to own up to an issue if their potential feedback from a trainer says, well, you don't look like you got Downs, you don't look like you got intellectual disability, you don't look learning disabled. Well, actually, he's not learning disabled, he's a doctor. He's very abled. Okay. And the other thing, by this individual now doing his own locums, he's got more control, you see, over shifts. Can you see? Depending on how... That's why people move their jobs, okay? They want to stay in their jobs at the end of the day.
That's a really good. I mean, it feels like we're moving towards the sorts of things that we can do to support these doctors. So, as you said, taking more control of those environments.
I think one of the challenges, Andy, is we're trained to look for problems. I think that, and which is right thing to do. We have to find problems, okay? But when we're talking to a doctor with neurodiversity, okay, don't look at the problem. Look at the talent and the skill, okay? Look at the strengths. Ask them, what are your strengths, okay? Have a conversation that way, not what are your problems, okay? I mean, they've already got issues of low confidence and concerns, worried about stigmatization. Don't go straight at them. Say what your problems are, okay? And also ask them what you think the solutions are, okay? As a trainer, educator, you don't have to have a magic wand to solve everybody else's problems, okay? Because usually the other person on the other side knows all the solutions. Now, how workable they are is a different thing, okay? How practical they are is a different thing, but that's not the first issue. The first issue should be, what do you think we can do to help you? Okay. Yes. I remember seeing a doctor with ADHD, and one of his big issues was that he works in a specialty where you have to wear one of those lead aprons. Okay. And, the standard size lead aprons you get. And what he really needed was an adjustable lead apron, which is more readily available for somebody who's pregnant, for example. That's all he needed. Okay. Because part of his job was, while wearing the lead apron, and again, this is a fascinating thing I find about neurodiversity, is he's got quite marked skin hypersensitivity. The pressure of the apron on his body is distracting him from doing his job.
Right.
Okay. So all he needed was a lighter apron, which is more adjustable. And I remember seeing this chap about 2 years ago, when he was struggling with the portfolio. There was issues on outside of work. Again, don't forget, doctors do have a life outside of work, and the life outside of work can be complicated. Okay. Yeah. And he had issues outside, and his relationship issues that kind of failed. And what I found was, as soon as we were able to persuade the employer, and that's sometimes the issue I find, that there's a genuine issue. Why can't we just get this guy an adjustable apron, coupled with, he started a new relationship in his personal life with an individual whose I think brother was autistic, okay, from memory, and by the new partner understanding the language, how to communicate with somebody with autism, okay, coupled with a change in the lead apron. I haven't seen this guy for 2 years. Good luck to the person. I hope he's doing well. I'm sure he is. Otherwise, it'd be in my clinic. So can you see how it's just simple changes?
Yeah, because a lot of people will say, extra time in the exam, or, some extra time in training. But it's becoming obvious that there's a whole range of different things that you can offer. And you can't just say, right, pick 5 out of these potential solutions and just implement them with this person. It really is a one-on-one sort of an individual type of program.
It is. Everything's bespoke. Yeah, this is where it bothers me is, like I said to you, just because you've seen one person with autism, you haven't seen everybody. Just because I've seen one doctor with neurodiversity, guess what? I haven't seen every single doctor with neurodiversity. And therefore, I just have to make a bespoke support structure. Some individuals have got a noise hypersensitivity, and maybe what they need is the ability to sit in a room, headphones on. They're not being rude. They need to, and they're facing the wall, for example, minimize visual distractions, minimize noise distractions, focus on doing whatever they're doing, okay? And now, with the pandemic, more understanding, perhaps in flexibility, that doing the admin work from home may be a suitable solution. Because as you probably know, Andy, when you were a trainee, there could be 16 of you in a room the size of a toilet as trainees, trying to be able to do your admin and your notes and everything. Whereas if we are just more open to flexibility, because doctors do want to do a good job.
Yeah.
Doctors do want to train, do want to learn the skills. They are genuinely interested, okay, in being the best version of themselves. And we just need to not get so confused about what I would call the general public with neurodiversity and doctors with neurodiversity. They're a different breed, okay, and we need to help them. Yeah. Very rarely there can be what I'd call a challenging breed. Okay, slightly eccentric, awkward, situational type breed, okay, which causes difficulty for all of us. You know, the employer, the TPDs, postgraduate deans, occupational health. I get that, you know, but that's human beings. You know, human beings are not all the same. We're all different for a reason.
There'll be people listening to this podcast. There'll be those who have gone away and Googled some stuff. Would you sort of caution against people coming up with suggestions to someone who they think, they might be thinking, I can, maybe you should try this or try that, and doing it themselves? Or should you really be seeing someone, like yourself or someone at the deanery who...
I mean, my take on it, a lot of not a lot. Ultimately, I think, Andy, we're all neurodivergent because we're all different. Okay. Yeah. Right at the beginning, remember, if you started off saying, about medicine is about, there's a blood test, there's a line, isn't it, where abnormal, normal. Okay. I don't think it's clear cut as that. I've always felt that it doesn't matter what the neurodivergent, well, actually it does matter, because there's a few people where you can't make any difference and they're going to struggle to be a doctor, full stop, okay? But the majority of individuals, 99%, they just need to understand that the right career, okay, in the right environment is all they need. And it may not be the career they've chosen ultimately at the beginning. They just need to be a bit more flexible, okay? Because I always say to these guys and girls is, don't you want to be happy? You are 32, 35, 38, all things being well, another 30 years before you can collect your pension, another 50 years before you leave this mortal coil. You've got that much time ahead of you. Do you want to be happy? Do you want to be not happy? What do you want in life? Okay. And it's up to them to decide what they want. But where there's a problem, Andy, is when the ability of an individual to do parts of the job puts patients at risk. Okay, and occasionally I'll get individuals come to me and says, but it is my right under the Quality Act 2010, I'm entitled to this adjustment. And generally they probably are. Okay, but let's not forget, this is still a job where you're working with human beings. Okay, and when you're working with human beings, part of our job as doctors is to make timely decisions with human beings. If it's taking you too much time to make those decisions, or you're too you're paralyzed by your thinking, okay, and you're struggling to make those decisions, it's putting patients at risk, isn't it? Okay, so I have to kind of remind everybody, the system, the trainer, the employers, that there comes an element where we need to make adjustments, but at the end of the day, if you feel as an ARCP panel, head of school, that despite making the adjustments, doing this, they've had 25% extra time for their exams, they're still not going to meet the minimum standard to meet all the curriculum requirements, okay? There's nothing wrong with an outcome 4. Okay. Because it's patient safety at the end. We need to remember that is the end product. And also these human beings, doctors, need to work with other human beings. These days, MDTs, we have to work with people of different variable skill sets, okay? And if you as a doctor with significant, but significant communication skills struggle to have balanced conversations with your peers, it affects team morale, team structure, team dynamics, team efficiency. It's difficult, isn't it? These things are difficult. Okay.
There's a lot that goes into it, isn't it, into a job like this? We've only got a few minutes left, but one thing I was wondering, you mentioned in our communication before the podcast was this idea of a dropped curb theory, and that sort of struck me. I just wondered if you were able to sort of summarise that.
I'll expand on that. Yeah, this is where I think there's two things I want to mention about that. I think I've been thinking a lot recently, okay, about this thing, and number one is diagnosis. Do we need a diagnosis for every single doctor? Okay, who's I'm coming nearer to the view now. Why don't we just have a simple conversation and put in the adjustments? Okay, long as they're doable, reasonable, practical adjustments. And when it comes to an adjustment, whatever it is, it has to still allow the doctor to meet the curriculum requirements, e-portfolio of exams, and upskilling themselves. Okay. All right. So if somebody says, I can't work for the next 4 years doing night shifts, because in nighttime hypersensitivity, whatever it is, they say, you think, hold on a minute, this is a 24/7 service. You've chosen to be in a profession, which is a 24/7 profession. As we know, cases present differently at 2 a.m. compared to 2 p.m. You know, if you work as a hospital specialist, we all know that at the end of the day. Okay. So it depends what the adjustments are. You know, they need to be timed, smart objectives, and reviewed. Okay. Yeah. Now, the drop step theory is really universal adjustments. Right. And the whole backstory about that is, you know, if you're walking down the road and the curb is dropped, not only is the person in a wheelchair, but also the mother with a pram, and the person with mobility difficulties able to go down that step and come back up the other step. Okay, so this is why the recognition we all need. We need to look at universal adjustments for all of us. This also brings me on to Microsoft 365, where, you know, it's got so many kind of add-on accessibility tools that I use myself. For example, the dictate function. You know, I speak with a microphone, hit the dictate button, I talk, my notes, emails, whatever, are done quickly for me. Okay, there's so much basic technology out there that we should be accessing on a day-to-day basis to make our lives easier as doctors. And again, I see doctors with, you know, organizational difficulties, and I say, well, have you thought about, you know, the Pomodoro technique, Eisenhower matrix for prioritizing, blah, blah, blah. None of this stuff we're taught, are we, at medical school? We'll bumble along.
I think we're starting to see that, certainly in my experience. You know, we're putting on, you know, study skills courses for people who are going into exams because there's something they've never learnt how to do or how to approach learning vast volumes of information. We're also, you know, we're making time out of training available to everyone, not just those who, you know, go off and have a baby or want to do any caring responsibilities. These things are coming in, aren't they? And
I couldn't agree with you more.
The feeling of this isn't just a problem. Yeah.
Yeah, I agree. I think having coaching, you know, mentoring and trainers having coaching skills is important. Yeah. Okay. Yeah. Right? Yeah. I've learned all those things deliberately myself because I've seen what's coming down the pipeline and I've seen what's happening. Okay. Yeah. And I think I need to upgrade myself, you know, on my abilities to have open but sensible conversations. I need to learn better language when it comes to chatting or discussing neurodiversity issues. There's lots of things I'm evolving my practice all the time and realizing, you know, that doctors with neurodiversity are a huge asset. And guess what? Neurodiversity didn't just suddenly arise 10 years ago. It's been there since humanity started.
Yes.
You know, it's just a term.
A lot of people, one of the things you might hear sometimes in workplaces, whether people sort of read around this topic and then they sort of self-diagnose, or whether people use the term in a kind of, I suppose manipulative is a bit of a strong term, but are there people who go out there and go, oh, I've got this, and because I know it brings with it various advantages, or does that happen?
The quick answer to that, Andy, is true. They are individuals, okay? But only time tells, I find. Only time tells you over a period of time. The individuals, should we say, are more... It's rare, okay? That's the first thing I want to say. It's rare, okay? But there are individuals who, sadly, because of certain personality traits, I'm not talking about neurodiversity traits, I'm talking about personality traits. And when you do a look-back exercise, you recognize that actually they've always been challenging in their abilities to kind of get what they want by using flexible routes. To get what they want.
Yeah, fair enough. No, that's encouraging that people can.
But I don't want people to say, because they all must be neurodivergent. No, they're not.
Yes, exactly.
One of the terms I sometimes use when I'm talking to my trainees, employees, workers, that you can be sad, you can be bad, you can be mad. Okay, they're not three individual things. You can actually get that combination with individuals as well, but it's very, very difficult to get to the bottom of. But eventually, you can get there. Okay, but that's very rare, And my experience of working with doctors with neurodiversity is they are very hardworking, intellectual, focused, driven to try to be creative, innovative, and they want to do the best they can, but sometimes they're challenged by the roll of the dice okay, where they've got some neurocognitive limitations. But having said that, I'm of the view, this is a personal view, that with the right level of support, why can't neuroplasticity help doctors with neurodivergency to change and improve with the right support? Okay, they can actually get better. Like I said right at the beginning, nurses were assumed with dyslexia were going to make drug errors, but actually the reality was they didn't.
It was the opposite.
Because they actually were more careful because they were self-aware.
Yeah. I'm conscious you've got another meeting, so we will have to draw this fascinating talk to a close. But just before we do that, I just thought if there was any really specific take-home points that you think are relevant. I mean, one of the things I think I would like to know, and a lot of trainers might like to know, is, where do we send people if we think they need that support? Is it to someone like yourself within the trust, or do you think that's better through a training route, the school?
I think increasingly what you've noticed is I have my arm dragged behind me now and I'm increasingly going around doing virtual talks to TPDs and trainers across the country now. And I'm up for a talk for the Feds conference at the end of the year, and so again, there's a recognition that we need to be much more bolder in talking about this. In May, I've been invited to the Faculty of Intensive Care Medicine at Royal College of Anaesthetists on I think it's 21st of May, and to do a talk there. So increasingly, I'm getting out there to have a very open discussion with trainers now. Okay, because I want trainers to do the right thing, but recognize there's a limitation sometimes. Rarely, a limitation where actually the right thing is an outcome for.
Yeah. Okay. That's good to know. And I suppose it's probably initially it's something that goes through the school, and then it can work with local sort of occupational health departments in the workplace. So,
Sure.
Well, that is brilliant. Thank you very much. I've certainly learned a huge amount just through the reading and us talking together. I'm sure our listeners will also take a huge amount from this. What we will do is we'll put some links into the show notes on the podcast so people can then click on the links and read a little bit more. I've certainly got a few, and I'll pick your brains and find a few more, no doubt.
Yeah.
But, thank you ever so much for joining us. We are just about on time, so
Okay.
I will let you go unless there's anything further you wanted to say.
No, that's fine. Brilliant. Well, it's nice to talk to you, Andy. Okay, and if there's a requirement for I shouldn't be saying this. If questions come in on neurodiversity, okay, and from the audience, and there could be a part 2 of this. I just think such a vital thing that we need to clarify. We just need to be fair.
Yeah.
Fair. Yeah. Okay, and reasonable and respectful, okay, and try to do the right thing at the end.
Yeah, well, it's good to know there's people like yourself sort of championing this really what sounds an area that's been ignored for such a long time. So it's good to know it's in safe hands. But yes, we will communicate any questions through the podcast through to you, and maybe do a follow-up podcast in the future.
Absolutely, which I'd be happy to do, because I think it's an important subject.
Great, thank you ever so much for your time. Have a good rest of the day.
Thanks for listening to the Faculty Focus podcast. If you liked the episode, please share with friends and colleagues. You can also like and subscribe to the show, and perhaps even leave a review. Clinical education can be tough, but we're stronger as a community, so if you have an idea for an episode or would like to come on and talk to us, do get in touch via email or Twitter. Details in the show notes. The Faculty Focus podcast, Community Development Showcase.